I'm Dr. Valerie Jackson. I'm a clinical assistant professor at the University of California, San Francisco. I'm a pain psychologist at our pain management center, and I work with patients with opioid use disorder and chronic pain. Today we'll be discussing stigma associated with opioid use disorder and how to combat stigma and improve patient outcomes. We'll start by defining stigma. Stigma is a concept including labeling of differences with undesirable characteristics or stereotypes, resulting in separation of us versus them. It also includes emotional reactions like shame, status loss, and discrimination. All of these can lead to inequitable health outcomes. Stigma also includes concepts at both an individual and a societal level. So let's talk about opioid use disorder, or OUD. From 1999 to 2019, nearly 500,000 people died from an overdose involving any opioid. OUD is a treatable disease that no one chooses to have. Only 20% of patients who have OUD access any treatment. This is in part due to stigma. Some common opioids include codeine, fentanyl, heroin, morphine, and other opioids on this list. Today, we'll address some of the unfortunate stereotypes associated with OUD, like patients are manipulative, dishonest, or dangerous. We'll address the emotional consequences that patients experience, like shame or unworthiness. And we'll address the structural discrimination from healthcare systems due to unequal access and unequal treatment. One such example of structural stigma is that many healthcare providers do not receive much, if any, training about substance use disorders. I'll highlight a few healthcare provider, or HCP, stigma effects. Stigma negatively affects doctor and patient relationships. It can lead to a breakdown in communication, reduced trust, and also patients can really anticipate being stigmatized. So patients might actually change their behavior due to anticipated stigma, or pick up on some of the expressed stigmatizing emotions like frustration that they might sense from their providers. We will introduce tools in 3 different areas to help you reduce stigma when treating patients with opioid use disorder, whether it's associated with illicit drugs such as heroin or prescription medication use. We'll be talking about language, risk factors, and diagnosis. Note that we will be using a harm reduction lens to reduce stigma throughout this video. Harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. It accepts that drug use is a part of our world and aims to minimize its harmful effects rather than simply ignoring or condemning them. We will not be discussing specific opioid use disorder treatments in this video, but rather we'll be addressing ways to reduce stigma of opioid use disorder, and we'll talk about some of the potential benefits. Some of the potential benefits include developing trust with your patients, reducing burnout via improved interactions, and actually improving the clinician-patient relationship so that you can have a better therapeutic outcome. Before we go on to the tools we'll be sharing with you, we'll introduce our patient Dion to illustrate some important considerations that could shape opioid use disorder stigma. So let's consider Dion, who enters the clinic casually dressed, requesting opioids for a recent injury. What are the ways in which Dion's personal characteristics could affect an assessment? Well, if Dion were male, he'd be more likely to be prescribed opioids for pain than if he were female. If Dion was male and diagnosed with OUD, clinicians would be more likely to offer or medication-assisted treatment. If Dion were white, Dion would be more likely to be prescribed opioids for pain than if Dion were Black or Latinx. Dion would also be more likely to have medical evaluations, things like a referral for an MRI or a CT. Dion would be more likely to be referred to pain management specialists, versus if Dion were Black, he'd be more likely to be referred to an addiction treatment center than if he were white. If Dion was white and diagnosed with OUD, clinicians would be more likely to offer buprenorphine. If Dion was Black and diagnosed with OUD, clinicians would be more likely to offer methadone. As a side note, buprenorphine is a medication that can be offered in an office, whereas methadone most often needs to be received in a clinic frequently. Additionally, community stigma associated with methadone is much higher than associated with buprenorphine. So multiple identities, such as, but not limited to, race, age, and gender, really affect treatment of pain and opioid use disorder. The research here tells us about our own biases. We may think we're being objective when we're assessing patients, but we're never actually fully free of bias. We will ask you throughout this video to reflect not only on a patient's medical content, but to also reflect on your own biases. With OUD, there's an inequity in healthcare settings. Each physician that provides a non-stigmatizing, comprehensive assessment will increase equity. Remember, we talked about common stereotypes of people with OUD. We want to approach patients from the perspective of seeing them as a whole person. So one way we can improve stigma of the opioid use disorder is by thinking of the language we're using. We'll start with using person-centered language. So instead of calling someone an opioid addict, we'll say person who uses opioids. Instead of former addict, person in recovery or remission. Instead of a drug seeker, person requesting opioid medication. An additional method of using language to cope with stigma is offering the patient normalizing statements. For instance, you might say to the patient, there are many reasons why people use more opioids than intended. Use a biological explanation. Things like craving, tolerance, withdrawal. You can use your experience and comfort as a medical professional to explain these things. Another normalizing statement you might offer a patient is, when using opioids regularly, whether it's prescribed or not, our bodies can start to desire more. It's a biological response, and it's not your fault. Cravings and tolerance can be challenging to overcome, but we can work together to address this. Another method of using language to help reduce stigma is connecting with your patients using motivational interviewing skills. You might start with open-ended questions, which actually dissuade one-word answers and encourage a dialogue with patients. You can ask questions like, how does it affect you? Tell me more about that. Would you share an example? You can also ask about the benefits of using opioids. This helps you connect with the patient and allows them space to discuss how opioids are presenting in their lives and some reasons that they're actually using it. You can also acknowledge ambivalence or challenges if they're presented to you, and assess readiness to change. For instance, you might say, I hear you're not ready to stop using fentanyl you're getting from a friend. Would you be open to talking about some ways to cut down or ways to make that use safer with things like Narcan? Remember, all of these skills that we've talked about is something like putting in a stent or intubation. These are skills that need to be developed and practiced and cultivated, and they'll improve over time. Let's discuss a couple other language considerations, as stigma can show up in subtle ways. Don't underestimate the importance of body language. Patients are picking up on that. Another thing is, we have very busy clinical schedules. It may be the 20th patient you've seen today, but keeping in mind that each one of these patients have an individual experience that may be very central to their lives. Conversations with our colleagues can actually trickle down and affect our clinical encounters. We may refer to patients as a frequent flyer or an addict, even when the patient's not present. And this actually does affect treatment and the biases that we hold against patients. Now, let's talk about our next tool to reduce stigma. It's a risk assessment for prescription opioid misuse. A common way discussions begin about opioid use are actually when patients request or have prescription opioids on their medication list. The Screener and Opioid Assessment for Patients with Pain, or the SOAP, is a research-based assessment for developing the risk of opioid use disorder. The SOAP has several versions, but the 24-item version is an evidence-based, validated, free, and it's also the most commonly used version. It can provide history and context for seeing the patient as a whole person. So let's talk about what it is. It's a 24-item research-based assessment to understand the risk of developing opioid use disorder from prescription medications. When do we use it? When a patient is requesting a prescription for opioids. You might also use it if you just see it on the patient's medication records. How do we use it? Most patients self-administer this. They'll fill it out prior to the visit, or you could even complete it collaboratively together and use it as a discussion point. What it tells us, when the score is greater than 18, that suggests that this patient is at risk for opioid misuse. So what do we do if a patient scores at risk? Use some of the language tips we just discussed: normalizing, active listening. You can also use this score as a tool to discuss risk of opioid misuse. That actually also helps reduce blame on the patient. This is a stigma intervention. You may review the SOAP-R responses and use some of them as discussion points. We'll highlight here 5 of the sample items from the 24-item SOAP-R. I'll also share some scripts with you that might be helpful for how to talk about a high score on the SOAP-R. If you're a provider who treats patients without a known history of opioid use, you might say, "We know that other people who've had some of the same answers as you are at higher risk for developing problems with opioids. Knowing that, let's have a conversation about the risks and benefits of starting opioids rather than other medications to manage your pain." Having an open discussion about the results of the SOAP helps start a conversation with your patients about why other pain medications might be preferred. It also demonstrates care about their individual treatment plan. Remember that the SOAP is meant to be used for patients who are taking prescription opioids, and this will allow you to have this conversation in the context of prescription opioid use. If you're a provider who are treating patients with a known history of opioid use, this is a different script you can use. We know that other people who've had some of the same answers as you are at higher risk for having problems with opioids. Given that you've used opioids before, I want to work with you to treat your pain as well as keep you healthy overall. Let's talk about some of the options for pain management or how we can reduce the risk of problems associated with opioid use. Having an open discussion about the results of the SOAP helps start a conversation with your patient about why other pain medications might be preferred, and it also demonstrates that you care about their individual treatment plan. Each physician providing a non-stigmatizing, comprehensive assessment will increase equity. And now we'll discuss the final tool I'll present today, the Opioid Use Disorder Assessment as defined by the DSM-5. Remember that when you're able to comfortably discuss the symptoms of opioid use disorder with your patient, you're actually reducing stigma by talking about opioid use disorder with confidence, just like you'd discuss any other medical condition. The purpose of this training is to familiarize you with the complete criteria and how to discuss symptoms with patients, rather than completing a full opioid use disorder assessment. So a sample script that you might share with a patient could sound like this. "I want to understand more about how you're taking or using opioids and how it might affect you. The following set of questions are related to your use of opioids, so they might seem personal. Please remember, I'm here to support you and not to judge you." You may also remind your patient that OUD is just another medical condition you're assessing for. It's just like any health assessment that you'd be doing for them. To understand the severity of opioid use disorder, if a patient has 2 to 3 symptoms, we would consider this mild. 4 to 5 symptoms are considered moderate, and 6 or more symptoms would indicate a severe opioid use disorder. Let's remember Dion, our patient from the very beginning, who receives different treatment depending on race or gender. Let's remember that your recognition of bias makes a difference when you're using this and all the other tools we present in this video. To combat stigma, have an open conversation with each of your patients, regardless of their background. Stigma can act as a barrier to treating each patient equally. Remember that there is inequity in OUD treatment. Each physician that provides a non-stigmatizing, comprehensive assessment will increase equity. For the opioid use disorder screen and all of these tools, a compassionate, understanding response that reflects the patient's experience will reduce the perception of stigma. It helps us align with the patient and keeps them open to continuing the assessment. And let's reflect on our tips from our language section. Consider normalizing statements we might use. So if our patient endorses, opioids are often taken in larger amounts or over a longer period of time than was intended, there are many reasons why people take more opioids than intended. It can be hard to change, but we can talk about ways to do that. If our patient reports a persistent desire or many unsuccessful efforts to cut down or quit opioid use, something we might say could be, it can be difficult to cut down or control medications or other opioids like heroin, especially if your body's gotten used to it. It's not your fault, and it doesn't mean you haven't been trying hard enough. And another tip from our language section, use your expertise as a physician to talk about the biological aspects of OUD. When using heroin regularly, our bodies build up a tolerance, and you might need more to get the same effect. This is a normal biological response, and it's not your fault. There's treatment that can help. If we approach opioid use disorder with an acceptance that patients may continue to use opioids, rather than if we promoted abstinence alone, this can provide a path to safer use and a reduction in difficulties associated with opioid misuse. As we conclude this presentation, here are some take-home messages I'd like to highlight. Stigma negatively impacts OUD treatment and outcomes. By taking a harm reduction approach, using non-judgmental language, and understanding the risk factors for inequitable treatment, we can improve patient care. We can reduce stigma together. Equity in assessment can reduce the gap in identifying and encouraging appropriate OUD treatment for all patients, regardless of background. Practice of using these tools will also help you feel more comfortable discussing OUD, and that actually helps the patient understand that it's just another medical condition to be treated like any other medical condition. Thank you so much for your time and for your commitment to supporting patients with opioid use disorder. In conclusion, my name is Dr. Valerie Jackson. Thank you for taking the time to view this video. I hope you found the presentation helpful and that you have success in treating your patients moving forward. Thank you and take care.